thank Dr. Piyush, Dr. Jimit, Dr. Rutul for involving DTEC in this important program, which is PSG. DTEC, as Purvi said, we are doing a conference in Mumbai in the month of May. It's an organization which is dedicated to only diabetes and technology. And this one is the 5th conference that will be happening in the city of Mumbai. So those of you who are interested in technology may join the conference. The topic given to me is basically AI and its use in GDM. So before going to AI, because I presume that many of the people here may not be very familiar with the terminologies which are used in AI, I'll just give you some definitions or some brief information about what are the different terminologies which are commonly used. So AI is a broad terminology, which means any kind of intelligence which is exhibited by the machines or the computers, and this has been there since many decades. So most of the machines, computers, mobiles that we use nowadays, they have some or other form of intelligence. Whereas machine learning is a specialized type or specialized field of AI in which, in addition to being intelligent, the machines also learn from the data. So the machines or the algorithms will take some data as the input, work on that and give you some output. And they will change their output based on the learning that they get from the data. So this is how the machines start learning from you. The examples will be you using Google for searching something and seeing the advertisement on the Facebook. So machines are learning that what is your preference of shopping or eating, and that's how they provide the advertisements to you. So that is a machine learning application. Then deep learning is again a highly specialized machine learning in which they use something which is mimicking the human brain. So there are deep neural networks which are algorithms, but there are multiple algorithms and they all mimic the neural network of the human beings. And there are multiple applications of that. I'm not going into details, but there are two terminologies which are commonly used. One is computer vision, which literally means the ability of a computer to see like a human being. So that is how the programs or the softwares can read the images, because they can see like a human being is seeing, or they can see the videos. That is computer vision. And the second is natural language processing, which means the ability of the machines to understand human language. So when you use something like a chat GPT, you talk in your language. Machines don't understand that language, but they have a capability now to understand, and that is through deep learning. The latest one, which is generative AI, which is the one which has created a lot of hype now in last few years, is the capacity where, in addition to doing all these things, the algorithms can create content for you. The content can be in the form of text, it can be audio, video, images, anything, and that is what is generative AI. So this was just to give you a brief idea about the different kinds of terminologies which are used in AI, and out of that, for GDM, particularly machine learning and deep learning is used, and that is what we'll discuss in the next few slides. So machine learning, and just to give a brief idea, there are multiple types of machine learning. The one you see on the left side is unsupervised learning, which means that no human being is supervising it. You feed some data to the algorithm, and the data will form, the algorithm will form clusters of similar looking data. So if you put up all these points here in the algorithm, they will separate out orange, red and greens. It's just to show you how it works. But the real life example is, many of you must have heard about the clustering of diabetes. Now we divide diabetes type 2 into SIDD, MODD and so on, and that is basically using AI. So they created clusters of similar looking patients. That is called as clustering or unsupervised learning. The second one is supervised learning, where while giving the data to the machine, there is a label. So you tell the machine that this is a photograph of a fundus of a diabetic retinopathy. This is a normal one. This is a NPDR. This is a PDR. The label is done. And from that labeling, the computer starts learning, and then it starts to recognize. So that is called as supervised learning. And then there is semi-supervised learning, which is a mixture of these. There is reinforcement learning. So these are the different types of machine learning. So we don't need to understand all these terminologies, but just to give a brief how it works. So in practice, this is the flow. So you have some clinical data. The point is not working, I think. So there is a clinical data between rectangle in the center. So there's a clinical data. The algorithm extracts the features from that, and then machine learning techniques are applied. There are several kinds of techniques. A few are listed here, and then they evaluate the performance, which is doing better. The one that is doing the best is selected, and then that is deployed. The model is deployed in the clinical practice. Once it's deployed, then it works on the patient's live data, and then it starts giving some predictions or suggestions for patient's treatment. This is how the overall flow of AI or machine learning works in the clinical practice. The same thing here. Now, how is it relevant for GDM? So We know that there have been so many changes in the definition of GDM. Earlier, probably a decade back, we were told that any kind of glucose intolerance detected for the first time in pregnancy is called a GDM. Now we know that only that which is detected after 24 weeks is actually GDM. The other one, unless it's a pre-existing diabetes, obviously. Otherwise, in the earlier period, if the sugar levels are in the clear-cut diabetic range, then we call it as pre-gestational diabetes mellitus. And there's a new term now, which is early GDM, where there is a mild glucose intolerance in the earlier phase of pregnancy. So there are so many things here. Now, the peculiarities about GDM are that the range of glucose where we are working is very short or very small. So between 150 and 90, there are so many things. I mean, blood sugar or blood glucose of 102 or 103 fasting is also abnormal for a pregnant lady, but not for a normal person. In pregnancy, the criteria or the glycemic control is stringent compared to the normal diabetic people, and we need to maintain that glycemic control throughout the pregnancy. So that is one challenge. Second challenge is that we have a very short duration. So by the time the lady recognizes that she is diabetic, she already has got 6 to 8 weeks of her pregnancy, and we know that organogenesis happens only in the first 8 weeks. So we usually miss this period, which is crucial for these babies. And then we again have a few weeks. During that time, if the control is not good, then the baby will be having macrosomia, there will be shoulder dystocias, cesarean section, and so on, and so many complications. And the last 2 weeks also are crucial, because if that period the glucose is not controlled, then there is a very high chance of neonatal hypoxias, hypoglycemias, hyperbilirubinemia, or thrombocytopenia and other complications. Now, the peculiarities in GDM are that we have to have a stringent control, and we don't have much of time. In diabetic patients, type 2 patients, you can give them a period of 2 months, 3 months for lifestyle. Here you just have a few weeks, so you have to take decisions very fast. Then, regarding the treatment also, although we have different guidelines, some would say give metformin in this period, not in that period. WHO now says give it to anybody. So whether to go for only MNT, if yes, how long? Should we give a trial for 2 weeks or 4 weeks? Should we start metformin every patient? Should we give insulin to every patient? Should we mix it? There are differences in the different guidelines. Now, this is a classical case where AI or machine learning can help us, because by using machine learning algorithms, we can personalize the treatment for that particular patient. It is not in clinical practice as of now, so the next part of my presentation will be of several papers which are done in this field. None of these might be clinically applicable right now in our field, but I'll show you the papers, and I'll give you the QR codes for all the papers where they have used AI or machine learning for GDM. So these are the areas where we can use machine learning algorithms for patients of GDM. One is for prediction of development of GDM. Somebody who is not pregnant yet, you can make the prediction that what are the chances of that lady getting GDM when she gets pregnant. You can use it for early detection in the first trimester itself, for precise diagnosis, and it has the algorithms which are there now. They have got a higher screening accuracy. Treatment personalization, as I said, whether to go for only MNT or metformin or a combination, and those things can be guided better by the algorithms nowadays. Outcome prediction, the algorithms can tell you precisely what is the risk of the patient getting so and so adverse outcome, and then you can provide a continuous support by using remote monitoring and the different applications which are using machine learning or AI. So these are terminologies we don't need to understand, but there are several algorithms of machine learning. Simply, if I want to say it simply, for random forest means there are multiple trees which are decision trees, and then the one which works best is chosen. The XGBoost is a better form of random forest itself. Neural network is something where they use the deep neural networks like human brain. The last one is logistic regression, the one that we learned in statistics, the same thing. And then there are so many advanced approaches like complex neural networks and automated machine learning and so on. We don't need to understand these things. We just need to know that the one which works best for a particular scenario is to be used. And this is a study, I will show the paper later on, where they did a study for looking at the USG of pregnant females and predict the risk of complications based on that. And then they looked at the accuracy of different algorithms, and then they selected that the one which is doing the best should be chosen for that particular algorithm. So starting with the different applications of AI in GDM, my time is running fast. Okay, so we know these are the conventional approaches for screening for GDM, and the consequences are that we usually miss it at the earlier phase. The glycemic control is not good, complications are increased. And so what can you do for early prediction? There are two studies that I'll show you here. The first one is for preconception model. So the lady is not pregnant yet. She has just come for preconception counseling. They had 222 Asian women, and they developed an algorithm which could predict the risk of that lady getting GDM in the future. The second one is a study from Iran, published recently in 2025, and here they used it in the first trimester for predicting the risk of GDM. Now, what are the markers that would tell the risk of GDM in that lady? These are the same ones that we use for our practice also. Pre-pregnancy BMI, family history, maternal age, ethnicity, previous GDM. Now you might wonder that what is different here then. We already know that if a patient has got high BMI or family history, she has a high risk of getting GDM. The difference is that we can only know high BMI or low BMI. We don't know the risk difference between a BMI of 23 and 27, or an age of 30 and 35, or a history of family history in one parent and two parents, or mother or father. With the algorithms, they can do the calculations. So you will have a different risk for a lady who is obese, BMI 30, than the one who is BMI 32, or a combination of BMI 30 and age 25, or BMI 32 and age 27. They will have different risk, and that can be exactly found out by using the algorithms. That is the role of this. So these are the papers. The QR codes I am showing only if anybody is interested to read these articles, they can scan the QR code. These are all free PDFs available. This one is the first one that I spoke about, which is for the pre-conception risk screening, and the second one is for the first trimester screening, the Iran study. I'll run it a little fast now. So this study, here they use the cell-free DNA. I never knew about this term. I just read it when Rutul asked me to prepare this topic. So cell-free, apparently in the mother's blood, there is fetal DNA, and which is not in the cell, it's outside the cell. So that DNA, the obstetricians, they usually take up the sample of mother, and from that they can analyze the DNA of the baby also. So from that DNA of the fetus, you can tell the risk of GDM in the mother, and this was a study done for that purpose, and it was found to be useful. Now the other slides I'll run a little fast because my time is running fast. Then they also used ultrasound based AI images, ultrasound images for predicting the risk of GDM. We know that GDM pathophysiology lies in the placenta, and you can pick up the placental morphology very well on ultrasound. So they did a study here where they looked at the ultrasound images of the ladies in the first trimester, and from that they could make a prediction of the risk of GDM. Then there is another one which is on stepwise prediction system. So here they use different levels. The level A is for early pregnancy, where they use only basic demographics as we discussed earlier. Level B is in the mid pregnancy, where they add the lab markers. And level C is at the diagnosis, where they add the complete clinical data, lab data, and it has got the highest accuracy. So this can be used for different tier systems. In the rural area, you can only use the history parameters. In a primary care, you can use the lab parameters, and maybe at a higher center, the other parameters also. This is a study again published on that stepwise prediction. Then there is a tool called GDM Predictor, which is an integrated system. So in addition to doing the risk assessment, it also gives the treatment recommendations for that particular patient. So this particular tool is also available online, and they have a website. Anybody who is interested can go to this website, bioinfogenetics.info/GDM, and if you go there, they will show you the tool like this, where you give the inputs, and then it will give you the risk of lady getting GDM and the preferred treatment for that particular lady. This is a paper that they published on that particular algorithm. Then for treatment modality prediction, there are 4 prediction time points. Level 1 for 1 year pre-conception, before the LMP, at the time of planning only, it could tell the prediction of the treatment which will be better for that particular female. Level 2 between LMP to GDM diagnosis, level 3 at GDM diagnosis, and level 4 at 1 week post-diagnosis. Again, the paper is here. Then for daily glucose management, so as Puri was discussing, it's very important for us to maintain the glucose control of the females in a tight range when they are pregnant, and the algorithms can also give the predictions about the possibility of hyperglycemias or hyperglycemias based on different parameters. So again, here they used different inputs, including the inputs from the EHR data, the activity, the food, and based on that they can make the predictions that the female might have a spike after the dinner or after the breakfast, and then you can change the treatment accordingly. This is the paper for that. Then for adverse outcomes for predicting the risk of macrosomia, this was a study done from China. There are multiple studies on that particular aspect also. I'm showing this one where they use the nomogram model, and then they could make the risk of, they could make the prediction about the risk of macrosomia to the tune of, with the AUC of 0.93, 0.90, which is supposed to be very high. This is that paper. Okay. And then neural networks for composite outcomes. This was again a study which was done for telling the overall risk of composite outcomes, like the risk of cesarean delivery, preeclampsia, NICU admissions, hypoglycemias, and they had a study with around 450 females, and the algorithm had an accuracy of 82% in predicting the risk of all these complications. For primary decision delivery prediction, again, this is another paper, and I'll just rush through that paper. Then there are various mobile health applications which are designed specifically for GDM females, and here they have different applications doing different job. So this was a good, just a minute. So it was a good review article, which I'll show you later on, where they reviewed all these different applications, and then they found that 8 of those were good. But among those, MOBI guide is the one which was actually approved by the regulatory bodies also in that particular country. This is the paper which talks about all these different ML applications, and these are the screenshots of that app. I could not find it on the App Store, but these are from a paper. So these are the screenshots where the algorithm tells the patient the recommendations for diet or exercise. So again, telemedicine can also be integrated with AI, and here you have 3 different areas: patient app, then AI decision making engine, and then a clinician dashboard from where he can monitor the patient remotely. This is a paper for that. And at the last, the people say that AI is a black box, so we don't know how the AI is working, the predictions that it is making, how it is making. So there is something called as explainable AI now, where you can understand why a prediction is made and identify which of the feature drives the decision. So if you know how the AI is working, we'll probably rely more on that, and then there are different techniques of that also. Then there is something called clinical decision support system, where you use the AI tools for helping you in making the clinical decisions, and there are different layers of that. And the future directions would be for precision GDM management, where we have the exact profile of a patient. We can exactly know what is the risk of getting complications, risk of getting GDM, and we can treat the patient with the individualized approach which will be fit for that particular patient. So my key take-home messages from this presentation are that although nothing is available right now in our country, but in near future we'll have several AI tools, algorithms which can make the predictions and detect GDM earlier. They can diagnose it precisely. They can predict the risk of complications. They can help us in personalizing the treatment of the patient. mHealth and telemedicine can be integrated to have more regular monitoring with the patient. But there are challenges which are ethical, regulatory, and in the implementation because of the lack of infrastructure. But the future is of personalized precision care. Thank you so much.